I'm Anthony Leeds. It's my pleasure to welcome you to my third discussion with my colleague, Professor Shahrad Taheri, who's based in the Department of Medicine in Leicester. We've discussed diabetes remission and fatty liver, and this week we're going to talk about obstructive sleep apnea, which is a major problem in some groups. Shahrad, thank you very much for joining me. And we should begin, I think, because we have to bear in mind that not everybody has seen some of the other programs explaining what is obstructive sleep apnea and what the causes are.
So obstructive sleep apnea belongs to a group of sleep disorders called sleep disordered breathing. Now, what happens during sleep is our muscles tend to relax. Particularly, we have two stages of sleep. One is called slow wave sleep, where we sort of pay what we call sleep debt. That means because we've been awake so long, we have to pay that through sleep and recovery. And another part of sleep is called rapid eye movement sleep. So rapid eye movement sleep is when your eyes flick from side to side. And we know during rapid eye movement sleep, your body is basically paralyzed apart from your diaphragm and your eyes, which flick from side to side. So apart from breathing, all the muscles are basically relaxed and sort of what we call atonic. That means there's no muscle tone. And this is because rapid eye movement sleep is related to dreaming, and you don't want to be acting out your dreams, running around chasing things and doing silly things. So that's what happens. So during sleep, our muscle tone goes down, and that's when our airway becomes vulnerable. Now, there are two ways that our airways could be affected. One is what we call central sleep apnea. That means if your brain doesn't tell you to breathe, doesn't send a signal for breathing, and these are really rare conditions. And the second one is what we call obstructive sleep apnea, where the airway, for whatever reason, is narrowed and becomes vulnerable when the muscle tone is down during sleep, becomes either smaller or occluded, and is completely shut down. When it's completely shut down, there's no oxygen going into the lungs, which results in lower oxygen levels in the blood. And this is a signal for the body that you're actually, in a way, drowning because your oxygen levels are going down. And this causes what are called microarousals. That means you wake up during sleep without realizing it. And some people may wake up with a snore or something like that. And because people don't realize that this has happened, when they wake up during the day, they're sleepy because their sleep has been disrupted. And because they're sleepy during the day, they tend to have increased risk of motor accidents and increased sort of work accidents and things like that. And sadly, what happens is these individuals tend to be bus drivers and quite a few tend to be truck drivers, lorry drivers who end up being sleepy, and that can cause accidents down the line. But we've also realized that sleep apnea is also associated with other problems, because when you stop breathing at night and your oxygen levels go down, this activates what we call your stress response, what we call sympathetic nervous system response, and this elevates your blood pressure. And it could be one of the drivers of hypertension. And also, because of the stress that it puts on the heart, there's a risk of what we call atrial fibrillation, which is abnormal beating of the heart in the atrium. And that beats in a funny way, in an irregular pattern that increases the risk of clots forming within the atrium that sends clots up that can cause strokes, for example. Additionally, because when you're trying to breathe, but the airway is blocked, what happens is you try to use your abdominal muscles to breathe and you can't breathe. And what happens is that pushes acid up. So many people complain of acid reflux, gastroesophageal reflux disease, where they get acid problems. And also when they wake up in the morning, they tend to report headaches. And we know that obstructive sleep apnea or sleep disordered breathing is associated with excess cardiovascular disease, reduction in quality of life, and also in men is particularly also associated with erectile dysfunction. So it does affect the general well-being of those individuals. Now, sleep apnea is a fairly prevalent disease. Depending on which population you look at. So if you look at the type 2 diabetes population, it can be as high as 50 to 80% prevalence in the type 2 diabetes population. In general population, depends what population you're studying, can be up to 10%. That means 1 in 10 individuals could be affected with sleep apnea. So it's a very prevalent condition, and it's important. It's also associated with poor diabetes control. And this comes from many studies that have been done before. So if you, for example, take animals and you expose them to low oxygen levels, they develop higher blood glucose. If you go up a mountain, you can develop something called altitude hyperglycemia. That means your sugar goes up because the oxygen levels go down as you go up a mountain. So low oxygen levels are associated with poor glycemic control. And we showed that in several studies. Actually, sleep apnea is associated with poorer blood glucose control in people with type 2 diabetes.
So how do people find out whether they've got it, and then what should they do about it?
So the main sort of symptom that people sort of talk about is snoring. But snoring, first of all, there has to be some air movement for the upper airway to sort of vibrate and cause that snoring sound. But if there's very little airflow, there may not be any snoring, for example. So sleep apnea could be quite severe without snoring. And people who tend to snore tend to sleep apart from their partner or whoever's going to observe them snoring. So it's very difficult to address snoring. But snoring is a common symptom that people report. Early morning headaches, poor diabetes control in somebody who's coming to a diabetes clinic and the diabetes control is not as good as it can be. It could be sleep apnea that's contributing to it. Atrial fibrillation, abnormal heart rhythm could be a signal to sleep apnea. But we also know that sleep apnea is associated with obesity, so excess adiposity, higher BMI. The higher the BMI you go, the greater risk of sleep apnea, and also certain ethnicities. So Hispanics, for example, in the US are at higher risk. We showed that South Asians are higher risk of sleep apnea compared to white Europeans in Birmingham. So these are all factors that come into it. But it depends also at the age of the individual as well. So sleep apnea occurs in 2 peaks. The first peak occurs in children, and that's related to tonsils. So no child should be snoring, full stop, unless they have a cold or something. That's temporary. But if they continuously snore, there's a problem, and we know that sleep apnea in children is related to reduced school performance and cognitive function. So it's very important to find those individuals early. The second peak occurs in adults, sort of middle-aged individuals. And it tends to be more common in men in the beginning until the menopause occurs. So when the menopause occurs, then women catch up in terms of sleep apnea. Now, what we showed was one of the very early studies. I think it was about 2005, 2006, where we showed actually obesity doesn't explain all of sleep apnea. So obesity explains about 40 to 50% of risk of sleep apnea. The rest has to do with the anatomy of the individual or airway control. So some people have got larger tongues, smaller jaws that pushes the airway back. They have different airway control. So the airway tone is not maintained during sleep. So there are different factors come into it. And obesity, excess body fat, particularly around the neck, is only accounting for about 40 to 50% of sleep apnea. And this fits really well because when you look at people losing weight, so sleep apnea can improve with weight loss. We did a systematic review that showed that dietary and lifestyle interventions, exercise, can improve sleep apnea. And bariatric surgery has been shown to improve sleep apnea. And a new medication, the GLP-1 based, what we call nutrient stimulated hormones, NUSH, such as GLP-1s, GLP-1, GIP, and to improve sleep apnea. But none of them will cure it.
No. No. So individuals really require referral to appropriate specialists, don't they? And preceding that, tests, or after that, have appropriate tests. The major method of intervention, though, is a mechanical one, isn't it? A CPAP machine.
Yes. Maybe we should sort of step back about the diagnosis.
Yes.
We talked about presentations of people in terms of the disease, but how can we identify these individuals? So people use questionnaires in terms of looking at things. So one of the questionnaires that's used is called the Berlin questionnaire. It's this question that was developed in Berlin, and that puts people into high risk and low risk in terms of sleep apnea. But we don't generally. It's not very reproducible, and we haven't found much success with that. But there's a question called a stop bang questionnaire, which looks at basically snoring, obesity, etc. Each of these stand within a stop bang protocol, and blood pressure. And this gives you a measure of whether somebody is at high risk of sleep apnea or not. So we use the stop bang questionnaire, which also looks at neck circumference, BMI, all the factors come into it. And then we also measure sleepiness using something called the Epworth sleepiness scale. People who score 10 or 11 or more on that sleepiness score, they're not at risk of excessive sleepiness. It doesn't tell you about sleep apnea, but it tells you how bad the sleepiness is. And the sleepiness may be low in people with diabetes. So that people with diabetes may not report excessive sleepiness, but they may have very severe sleep apnea, for example. So you have to put the two together, stop bang questionnaire and sleep apnea. So once it's diagnosed, depending on the severity, so sleep apnea is diagnosed using different methods, and this requires a sleep study or measuring oxygenation at home, or coming into a lab to have a full sleep study. So what we measure, if we're measuring oxygenation, we measure what we call oxygen desaturation index, how much your oxygen drops overnight, and that's done through pulse oximetry. And if they come into the lab, we measure what's called the apnea-hypopnea index. So apnea is stopping breathing completely, hypopnea is reducing breathing, and both of them are with lower oxygen levels. And the number of apneas and hypopneas per hour of sleep is your apnea-hypopnea index. And anything 5 and above is considered sleep apnea. And when you get to 15 to 30 is moderate, and then becomes severe after that. So usually people use oximetry because it's cheap and effective to do that, but that can miss some of the other forms of sleep apnea. So depending on the respiratory clinic that you refer to, they can do any of these tests to identify sleep apnea. And as treatment of choice, most guidelines say lifestyle intervention is the beginning. And I strongly believe in that, because we've shown that even although it doesn't, weight loss and improve your lifestyle doesn't necessarily cure sleep apnea, but it actually does improve it. That's really important to take that into account. But you need to achieve fairly large amounts of weight loss. Again, this is not achieved through your average diet. So you may need total diet replacement or bariatric surgery or medication to achieve that reduction. And the next treatment is called continuous positive airway pressure, which is like a reverse vacuum cleaner. Basically, it's when doing expiration, when you're breathing out, it blows some air to keep the airway open. Now the problem with CPAP is some people find it claustrophobic. Some people don't like the way the mask is. So there are new approaches being used in terms of matching the mask or how this air pressure is delivered to the patient's anatomy. So, and the machines are getting smaller and smaller in terms of being able to travel with it. But obviously, it's not a very pleasant thing to do, but people realize actually it does help them in terms of being more alert during the day. CPAP improves alertness in terms of activity during the day, but hasn't been shown to actually improve cardiovascular disease outcomes. So there are large trials done with that. CPAP hasn't shown that. But we've observed that CPAP actually those who receive CPAP with type 2 diabetes can have better glycemic control and better blood pressure down the line.
Mm-hmm. And presumably, ideally, particularly in people with diabetes, we would want to achieve some weight reduction as well, which should give some of the cardiovascular improvement as well, shouldn't it? Yeah. Are there any further advances to make in that area in relation to obstructive sleep apnea? What are the as yet unaddressed issues? Is it cost effective to do all of the various interventions that are possible? What proportion of people in the United Kingdom actually manage to get the treatment they need, and how many remain untreated?
Well, worldwide, first of all, is that the recognition of disease is poor.
Yeah.
So not many people get tested, and not many people have access to testing in a timely manner, and it's a problem across the world because people don't think about it. If you don't think about sleep apnea, the patient comes, for example, to a diabetes clinic and they have their own 4 different medications for blood pressure, but nobody thinks about sleep apnea as a contributor to that. And I've had patients that have multiple cardiac ablations trying to burn their heart to stop the abnormal rhythm, and nobody really thought about sleep apnea as a contributor to that. It's really important for us we need to think more broadly in terms of what we do. And the same is true with obesity. So if a respiratory physician sees a patient, they have to go and see what the underlying issue is with that individual rather than treating the disease itself and the symptoms of that disease. Same with the cardiologist, gastroenterologist. And we know when you have 30 to 40% of the population affected with obesity, there is an underlying problem that we need to address. And that's the key. Recognize the disease, think about it, and many patients would drive to diagnosis themselves. So actually, I'm really tired during the day. I've searched the internet or talked to friends, family, and that's how I really want a sleep test.
Yeah, I mean, I know from talking to various people that the people in the United Kingdom who manage very large commercial fleets actually have very good processes whereby they are aware of the problems of overweight and sleep apnea, and certainly commercial vehicle drivers, I think, are now much more aware of the possible problem. In my own experience, I've just found helping these people to push them through quickly quite difficult to do, and the system doesn't seem to be as quick as it should be. But I think there is more awareness among the commercial driving industry. But generally, there's a need for education, I suppose, and then also, have we got sufficient facilities, for example, among all our various sleep clinics? Is the capacity there? I do know that some of my patients had to wait an extraordinarily long time to actually get the sleep test actually done. What do we need to do in the UK?
Well, again, it's a lack of recognition of requirement of what's needed to address these issues. And sleep apnea is a serious issue. And when you have 30% of adults having obesity, you're going to get a high prevalence of sleep apnea. And this goes across all sectors of life, including the military, for example, have CPAP units, believe it or not, in terms of managing people who have sleep apnea in the military. So again, we need to take this seriously, because some of the major, let's say you have a road traffic accident, for example, and the motorway gets blocked for some reason, that can cost between £3 to £5 million because of work loss, people not being able to get to work, all the delays, so it can be incredibly costly. So you really need to think about how best to diagnose. Again, we've been working on terms of developing biomarkers, so proteins that can be measured in the blood that can help identify sleep apnea. So these will be coming as panels in the future. We can use a blood test to quickly identify individuals various diseases like fatty liver, as we discussed, and sleep apnea.
Yeah, I mean, I recall you did write a paper on these markers in relation to sleep apnea and did identify very specific patterns which were associated with sleep apnea. Has anybody done the prospective studies, I hope they have, whereby after treatment that those panels are repeat measurements to see what happens to those marker proteins? Has that been done?
Yeah, actually the study that we did included people who were treated with CPAP as well, and showed that we identified over 60 markers that were associated with sleep apnea. And then we also looked at those markers and which ones would improve with CPAP, and some of them did improve with CPAP. So it's also possible to tell who's actually responding to CPAP treatment or not. Again, that's really important because there are, like any treatment, you have responders and non-responders. There's no benefit to continuing a treatment that's not working.
Good. So it would be appropriate at this point just to point out that, as usual, some information is provided underneath the video window with a little bit of text and some web links, which includes links to places where you can look at the questionnaires which are available for the first self-assessment in terms of sleep apnea risk. Do you have any further advice to give to people who suspect that they might have sleep apnea?
I think that if you really think about it, the key point is if anybody observes you stopping breathing during sleep, that's a really good telltale sign of sleep apnea.
Yeah, thank you. And with the availability of phones on cameras now, certainly in the clinic I've seen recordings that people have brought in to show that. So that's actually a very useful new technological development, which has been very helpful. So that would be a good point at which to end. Thank you very much, Shahrad Taheri in the Department of Medicine in Leicester, for talking to us again. And hopefully in the fullness of time, when we have more to talk about, perhaps you would join us again and tell us about those advances, especially that one that you just told me about in the second programme, which was about markers in relation to dementia. Perhaps we can come to that on another occasion in the future. Thank you very much. Thank you. Thank you.